right, good evening. Again, welcome to the 2020 virtual Zoom version of MTSU's Strickland Visiting Scholar Lecture Series. My name's Lynn Nelson. I'm a professor here in the Department of History, and I'm also the chair of the Strickland Scholar Program Committee. Just have a couple of technical comments for how we're going to work this online this time around. Our chat function is disabled. However, if you'd like to ask questions of our visiting speaker, if you look down at the menu bar near the bottom of your Zoom screen, you'll see a little button for Q&A. If you'll hit that, that will bring up a box in which you can type in a question that you have. Do that at any time during our speaker's talk. My colleague, Dr. Lisa Pruitt, also the Department of History here, will be going through those questions, vetting. We obviously can't answer every single one, but she will be choosing some that will be able to give to Dr. Hammonds near the end of her talk. Now, at this time, I'd like to go ahead and turn the program over for some information about the Strickland program and an introduction of our visiting speaker. This is the chair of the Department of History here at Middle Tennessee State University, Dr. Emily Barron.
Hello, my name is Emily Barron, and I'm the chair of the History Department here at Middle Tennessee State University. It is my great pleasure to welcome you all here to our first ever virtual Strickland Scholar Lecture. The virtual format may be new, but the Strickland Visiting Scholar Program is not. This program, created from the Roscoe L. Strickland Endowment, has an established history of bringing the most distinguished historical scholars to MTSU. The unusual, to say the least, conditions of 2020 have meant that we cannot welcome Dr. Hammonds to our campus as we have previous Strickland scholars. Normally, our scholars have an opportunity to meet faculty, students, and the broader community, and we have the opportunity to spend time with them face to face. That said, the virtual format this year gives individuals all over the country, even the world, the chance to join us and benefit from the Strickland Scholar Program, even if only from their living rooms. I'd like to thank the Strickland family for establishing this wonderful resource for our university and community, and for continuing to support it year after year. The endowment honors the legacy of Roscoe L. Strickland Jr. and Lucy Strickland. And for those who have not had the pleasure of joining us for previous talks, I'll note that Roscoe L. Strickland was a founding member of this university's history department, and he later served as the first president of the Faculty Senate. Lucy Strickland, also a faculty member at MTSU, served as the very first president of the Murfreesboro League of Women Voters. The Strickland family has deep roots in our university and our community, and this endowment is just one piece of this broader history of service. We are so grateful for their generosity and support. Thank you. I'd like to also briefly thank the History Department Strickland Scholar Committee, its chair, Lynn Nelson, and our executive aide, Victoria Richardson, for planning and organizing the event. Thanks as well to Matthew Hibden and Albert Wittenberg for helping us navigate the uncharted waters of the virtual Strickland and making sure this evening runs smoothly. And now, it is my deep honor to introduce our speaker for this evening, Dr. Evelyn Hammonds. Dr. Hammonds is the Barbara Gutman Rosencrantz Professor of the History of Science at Harvard University and chair of Harvard University's History of Science Department. Dr. Hammonds' work focuses on the intersection of science, medicine, and race in the United States. Her first book, Childhood's Deadly Scourge, examined a diphtheria outbreak that ravaged New York City. And her work since then has continued with these themes of how race, but also gender, intersect with public health and science. Dr. Hammonds' career is one of remarkable depth and achievement. It should perhaps also serve as evidence that historians can in fact do math, something I tell my undergrads on a regular basis. As an undergrad at Spelman College and Georgia Institute of Technology, Dr. Hammonds earned 2 degrees, one in physics and another in electrical engineering. She then went on to earn a master's degree at MIT and initially worked as a software engineer. Eventually, she decided to switch career paths and study history, completing her PhD at Harvard University. She returned to her alma mater, MIT, and became the founding director of its Center for the Study of Diversity in Science and Technology. In 2002, she joined the faculty at Harvard. We are so honored to have Dr. Hammonds with us for our 2020 Strickland Visiting Scholar Lecture. Thank you, Dr. Hammonds, for sharing your research and work with all of us this evening. The floor is yours.
Okay. Can you hear me now? Okay. Thank you so much for that wonderful introduction. I am so happy to have this invitation to to give the Strickland lecture today. I'm so sorry that this is a virtual meeting and a virtual visit, but I hope you'll invite me back sometime to spend some time with you all on campus sometime in the near future. And you all know that the reason I can't be there is because we are in the midst of a pandemic of COVID-19. And so today I want to talk with you about my current work, which focuses on analyzing the historical factors that have led to the disproportionate impact of COVID on African American communities in the United States. So for historians of medicine who study disease, we use epidemics as a kind of sampling device. As Charles Rosenberg noted, it means that epidemics can illuminate fundamental patterns of social value and institutional practice, as he said. Until the outbreak of HIV/AIDS in the 1980s, we had, historians that is, had become accustomed to thinking that our modern society was no longer subject to widespread, uncontrolled infectious diseases, like those of tuberculosis or cholera or smallpox in the 19th century and even further back in human history, such as outbreaks of the plague. We thought that scientific medicine had brought us into a new age that would be free of such scourges. And AIDS was surprising to us then, and it had a significant impact on our society and social relations. And I'm going to share my screen now for my slides. And so for historians of medicine, the AIDS epidemic really brought out a singular and important point. Its brief history illustrates both our continuing dependence on medicine, for better or worse, and the way that disease necessarily reflects and lays bare every aspect of the culture in which it occurs. But even as we recognize that about AIDS, what has happened recently was nothing. AIDS was nothing, I should say, like what has happened in the last 7 months with the worldwide pandemic of COVID-19. So as I noted, what I'll be sharing with you today is some of my work on the impact of COVID-19 on African American communities. So first, I just want to say something that I think is really important as a message to take home. Pandemics, about pandemics. Pandemics don't produce inequalities, they reveal them. And these two crises that we've experienced in the United States in the summer of 2020, escalating police violence and a worsening pandemic of COVID-19, both have disproportionately targeted communities of color. And while the killing and maiming of people of color by state authorities is far more visible, the extraneous failures in healthcare and public health are much more numerous. The privatization of healthcare and the failed policy decisions by the US government have led to persistent, stark racial disparities in health. And the corona pandemic revealed and exacerbated these disparities. So for COVID-19, what we know is this, that Black and Latino Americans are roughly 2 to 3 times more likely than their white counterparts to contract the coronavirus, roughly 4 times more likely to be hospitalized by it, and nearly 3 times as likely to die from it. Latino children who contract the virus are 8 times more likely to be hospitalized than white children, and Black children 5 times more likely. And of the 121 children who died from the virus through July, nearly 80% were children of color, 45% Latino, and some 29% Black, according to the Centers for Disease Control and Prevention. So doctors and scientists who track counts, cases and counts and death tolls are uniformly horrified by this disparity. And many worry that the true gap is probably even greater than the available data indicates. As one physician noted, we are looking at a historic decimation of the Hispanic communities in the United States. Not only are they dying at much higher rates, but they are also dying younger, which means we are looking at losing working aged parents and parents of school aged children. Now, for African American communities, there have been a set of predictable explanations about the health disparities and the disproportionate impact of COVID on that community. It's been ascribed to a number of factors. One, high rates of existing chronic diseases, such as diabetes, hypertension, asthma, and obesity. Two, greater likelihood of being uninsured and thus less access to healthcare. Three, more exposure to the virus due to holding more low-wage jobs in food services, public transit, and hospitals and other kinds of public-facing jobs. Four, decades of discrimination and distrust, leading to avoidance of the white-dominated healthcare system. Five, early on, there were rumors that Black people were actually less susceptible to the virus. Or in other cases, rumors on social media claimed that African Americans were more susceptible to the virus due to biological differences between races. Six, another predictable explanation was structural inequalities in health, wealth, housing, and education. And this is what I would say, and why I call them predictable explanations, is because points 1 through 6 are elements of every outbreak of epidemic disease in US cities that I have studied from the 18th century to the present. There's always been these kinds of explanations put forward by various observers about why an outbreak of epidemic disease disproportionately impacts certain communities, and in this case, African Americans. So the question I want to explore with you tonight is, how did we get here? And so I would start by saying the roots of all these disparities that I've noted are deep and difficult to disentangle. Chronic illness might stem clearly from diet and a lack of health insurance, but that doesn't really explain why Black and Latino Americans are more likely to suffer from food insecurity or to work in low-paying jobs in the first place. To answer these kinds of questions, we have to dig deeper into housing issues, immigration issues, education, labor policies that date in some senses and in some cases to the nation's founding. One population health specialist noted the ultimate driver was systemic racism. And that is one that has come to the fore more and more over the course of this pandemic. And the next point I want to make is, in this talk, I want you to understand that history matters. So what I will discuss today is I want to briefly describe some of the factors that have shaped the health status of African Americans over time. Because this is what we need to understand if we want to find out some of the reasons why health disparities exist. And we have to start with what happened at the end of slavery. We have to continue to analyze the failures of Reconstruction, which occurred through to the 1870s. We have to deconstruct how theories of racial differences provided a naturalistic explanation for restricting African Americans' access to jobs, education, economic opportunities, and adequate housing, and how inadequate housing affected health status. And we have to also demonstrate how public health practices beginning in 1900 or so focused on keeping whites separate from Blacks who were viewed as sources of contagion. This is a long list of historical ideas and issues that we have to understand, analyze, I should say, in order to understand health disparities with respect to African American communities. And some of this work has been done, but there's a lot more to be done. So the health conditions of the enslaved Africans. This is all going to be quite brief, just to give you a sense of what's been going on and what we know from the historical records. We know that enslaved Africans suffered a variety of miserable and often fatal maladies due to the Atlantic slave trade and to inhumane living and working conditions. Common symptoms among enslaved populations included things like blindness, lots of abdominal swelling. People Observers noted that many of the slaves had bowed legs and skin lesions, and some suffered from convulsions. And common conditions included deficiencies in vitamins like beriberi or pellagra, which was also caused by a vitamin deficiency, and other associations with vitamins, including, the low intake of vitamins, including rickets and kwashiorkor, which is also caused by severe protein deficiencies. We know that things like diarrhea and dysentery, whooping cough, and respiratory diseases, as well as issues like worms, really pushed the infant and early childhood death rate of slaves to twice that experienced by infants, white infants and children. And then we go from the period of slavery and approaching toward the Civil War. And the Civil War, like all wars, gave rise to explosive epidemics and high mortality due to the inability, especially at the end of the war, of the newly freed African Americans to secure clothing, shelter, and food, which left many of them dead. In addition, at the end of the Civil War, there was a devastating smallpox epidemic that raged across the South between 1862 and 1868, which exposed this newly vulnerable population to a disease, though controlled among many whites, was left largely uncontrolled among the freed population. This broad smallpox epidemic, and there are some currently a set of new works that are examining how the smallpox epidemic moved across the South in this period, and it just wreaked unbelievable havoc upon Black and white populations because it was wartime. And the expectation of what happens in wartime is that it's very hard for any institutional response to something like an outbreak of smallpox. And that was certainly true in this period. After the Civil War, in the absence of land reform, the newly freed people were forced to depend on help from the Federal Freedmen's Bureau for food, for clothing, and for shelter. But when this bureau was shut down in the 1870s, Black people had few resources to care for themselves. And since they were left landless and impoverished, what ensued was what the historian Jim Downs has called, quote, the greatest biological catastrophe of the 19th century. As epidemics of smallpox, cholera, yellow fever, and other diseases ripped their way through starving and ill-housed people, leaving at least a million dead or injured. We don't quite have the most robust numbers about this, but we know that it was very large. The public health response. For many white Southern pro-slavery advocates, the high rates of death and disease provided evidence that slavery was not a wholly cruel institution, because at least Black people had been provided with clothing, with housing, with food, and with work. Whereas in the post-slavery and the post-Civil War period, it was clear to these white observers that Blacks could not provide even a modicum of protection for themselves. And they argued that this population would surely die out. And some even predicted that they would die, that the population of African Americans would die out by the year 2000. But between the 1890s and into the late 1890s, one historian, Megan Wolfe, notes that the overall mortality of Blacks in Southern cities was 1.6 times that of whites. The economic and social roots of the condition of African Americans were written out of the discussion entirely. So no one talked about environmental issues. Nobody talked about the absence of land, of ownership of land, of the absence of economic opportunities. White observers, and including the very famous Frederick Hoffman, who's the insurance statistician at Prudential Life Insurance Company, who wrote the famous treatise, Race, Traits, and Tendencies of the Negro. He argued that Black people were dying because of their inferior status, and this had become accepted as defining attributes of the Negro. And he argued Negroes died because they were inferior, and they were inferior because they died. And this became a characteristic that was associated with African Americans that was considered to be an innate racial difference. That was defining characteristics of African American peoples and demonstrated their difference from white populations. So, of course, in the absence of any help, the problem worsened in the late 1890s. Limiting African Americans' access to land ownership and economic opportunity everywhere exacerbated the conditions that spread epidemic disease, spatial segregation, poverty, and a healthcare system that all but ignored them. In the early 20th century, public health practices focused on keeping Black and white people separated, refusing to address squalid housing conditions, restricting access, but at the same time, restricting access to hospitals and routinely referring to Black people as pests and sources of contagion, which affected their access to employment as well in many, many sectors. Now, these kind of characterizations of African Americans as a diseased and debilitated race was something that by the early 20th century, African Americans began to challenge quite seriously. In fact, these notions had been challenged early on, but that was sort of the voices of opposition to these kinds of ideas increased by the beginning of the 20th century. And one of the most famous rebuttals of the kinds of comments made by people like Frederick Hoffman in his piece, The Race, Traits, and Tendencies of the Negroes, came from W.E.B. Du Bois. And published in 1906, The Health and Physique of the Negro American. It was the first significant scientific approach to the health problems and biological studies of the Negro. And Du Bois included data on skin color, hair type, morality, the Negro as patient, on issues of migration, because at this time, more African Americans were leaving the South and going to cities in the North. He talked about the effects of freedom on the physical and psychological development of the Negro, which of course is the term used at that time. He went through a lengthy examination of various ideas about racial differences in body parts, including the femur, the foot, the eye, the prostrate, the spine. He examined data on muscle anomalies, ear structure, the skull size, brain, skeleton, pelvis, and ovaries. And so it's important to understand why Du Bois had to make such a detailed study of the data that was out there, which had been provided largely, almost universally by white physicians in order to counter the sort of notion of Black people as a diseased and debilitated race. And on the issue of body parts, it's really important to recognize that by the 1900s, there were comparative studies between whites and African Americans that really looked at almost every single body part and compared which one was what kind of differences there were in body parts between whites and Blacks. And almost universally, it would be that the Black body part was sufficiently inferior to the white body part. And so Du Bois knew of this great body of literature, and he needed to counter all of that in order to make a different kind of point. He also looked at disease processes, included the production of fibroid tumors, eye diseases, general kind of disease peculiarities that white doctors talked about. And he focused a great deal on tuberculosis, which was something that was a really one of the most significant diseases of the 19th century. More people died of tuberculosis than probably any other disease across the 19th century. He looked at issues related to diseases like anemia and also typhoid, which is also could become epidemic. It was also something that people were deeply concerned about. So what Du Bois did was really take each of these points, for example, the foot, and go through the literature that had been written about the foot, and then offered a different explanation for the differences that white physicians had claimed were due to innate racial characteristics. Du Bois was interested in understanding the relationship between environment and disease, and that these racial differences that people had characterized, he argued, had to be also affected by differences in environment and in diet and ways of life. And he concluded that much of the data that was out there was absolutely incorrect, that had been made by people just making off the cuff observations, not serious or systematic studies. And Du Bois in this paper, which is almost a small book, Health and Physique of the Negro American, he also did a lot of this work in the Philadelphia Negro, where he went block by block in Philadelphia, really measuring all kinds of differences due to environment, to sanitation, to quality of water, to work conditions, and all of this. And in many respects, as some of this newest work on Du Bois has shown, was one of the first really rigorous social scientists in the United States. And a lot of what he wrote about has held up by observers today. And so Du Bois concluded not that African Americans were going to die out, but he argued that with improved sanitary conditions, improved education, better economic opportunities, that the mortality of the Black race may, he argued, and probably will, steadily decrease until it becomes normal. So he believed that if the living conditions and economic opportunities of African Americans change for the better, then mortality rates and this devastating burden of disease that was really rampaging through Black communities at the time would not be the same, that it would be lessened considerably if these kinds of consideration, if these kinds of environmental changes would occur. And Du Bois's work, as I said, was one of the earliest and most detailed discussions of the health status of African Americans. And this work inaugurated a series of responses by African American health professionals that continues to this day. This is the first period of time when issues related to health status and economic status were foregrounded by this new group of African Americans who are now trained as physicians and social scientists, and some even working on in government agencies. So these early social scientists and these early African American observers challenged the view that African Americans' poor health status was proof that this population was racially inferior. But we enter in the period post-1900 into the period of Jim Crow and segregation. And in the early 20th century, the health status of African Americans were severely impacted by segregated, by the practices of Jim Crow laws. The problem worsened. It limited African Americans' access to land ownership and economic opportunity everywhere, and exacerbated the conditions that spread epidemic disease, spatial segregation, poverty, and a healthcare system that all but ignored them. Indeed, this is the moment when the Black hospital movement began. So African Americans who were restricted whose access to white hospitals was restricted began to build their own hospitals, their own medical schools, and their own nurse training schools, because they realized that if they were not going to have access to these other institutions, they had to do it for themselves. And the wonderful work by Vanessa Northington Gamble notes that in the title of her study of the Black hospital movement, making a place for ourselves. And so this is a crucial time. More and more of medical care was happening in hospitals. And so the absence of hospitals in African American communities was again had a severe impact on their ability to respond to outbreaks of disease. At the same time, in the early 20th century, public health practices focused on keeping Black and white people separated. That's, of course, what Jim Crow was all about. And again, the public health experts felt that by keeping the two populations separate, by restricting access to hospitals, this could prevent the diseased race, that is Black folks who were seen as the reservoirs of a lot of disease, could be stopped from spreading diseases to white populations. And therefore they characterized Black populations as the sources of disease, as pests, and because they were also seen as sources of contagion, they restricted their access to employment in many ways as well. So we go from a period when African Americans found themselves ravaged by outbreaks of epidemic diseases, began to leave the South where they had very little support and treatment and care, moved to cities of the North where there was still a great deal of segregation as well, and began to develop healthcare institutions for themselves. Along with the development of new healthcare institutions came the work of African American benevolent associations, which emphasized to Black communities and Black individuals the need to practice healthcare for themselves, to try in their own communities to have cleaner water, to work hard on issues of sanitation, to also at the same time, these were the same people who supported increased education as well. And these were organized in almost every city where groups of African Americans, certainly those who were upper class and middle class, who worked to change the conditions that were that were causing so much disease and death in their own communities. And that activism that African Americans engaged in during that time is the subject of many really wonderful historical analyses, which I think that the issue of health activism is something on the part of African Americans, that is something that many people don't know a lot about. But those communities were extremely active in those times. And the development of a number of African American hospitals was also important. But the hospital movement was moving very fast. And we're talking about communities that didn't have a lot of resources, economic resources, to support hospitals. And so many of the hospitals that were started by African Americans did not survive throughout the early 20th century. And so African American leaders turned again to work with getting the federal government to open up any kind of public facilities to African Americans and not just restrict them to whites. But what we know is that the health disparities that we have seen continue. And these continued differences in health was apparent even in many places in the South, even in a place like North Carolina, which Ed Beardsley talks about in his wonderful study, A History of Neglect, Healthcare for Blacks and Mill Workers in the 20th Century South, which I highly recommend. It turns out North Carolina had been a place where there had been, it was a region where they were leaders in public health programs and commitment. But what Beardsley notes that by the 1980s, so we're talking about now, I'm sort of covering some material that speaks to issues that were still at play from the early 20th century into the 1980s. And he notes that the North Carolina Board of Health at that point published an accounting of the 10 leading causes of death for whites and blacks. And it revealed that with two exceptions, Black men and women perished at rates that were consistently and significantly higher than white rates. The persistence of such differentials in the 1980s, he wrote, was a grim reminder that too large a proportion of Black families in North Carolina and every other Southern state lived outside of every legal, medical, and social advance our nation has made in this country. I was completely struck by his argument in this book because it showed the ways in which our public health system had become deeply fragmented. In some places around the country, in some states, public health was fairly uniform, and many of the population had access to good preventative work that public health agencies were doing. But in other parts of the country, it was very fragmented and different, and had a disproportionate impact on certain communities, and certainly for African Americans. And so the point I'm trying to make is really explained in this chart, and I hope you can see it. The first one is age-adjusted mortality between whites and blacks from 1900 to 2020. The light blue line is for Black Americans. The dark line, the green line, is for white Americans. So what you can see is that no time between 1900 and 2020 was the mortality rates of blacks equal to or lower than that of whites. This shows you the health disparities gap that we have in this country. And then you can look at the second chart and look at life expectancy rates between 1900 and 2020. And what you'll see is that the highest ever Black life expectancy, which was in 2014, was below white levels and had been there since the 1980s. Okay, so it meant that Blacks had lower life expectancy than whites, and it was less than that of whites every year but one. And that was in the period between 1900 and 1918. And we're still trying to figure out what exactly was happening there. But we do know that the influenza in 1918 had a terrible impact on white Americans, that influenza, which is again still being studied, had a terrific impact on a significant, I should say, impact on whites during that particular period of time. But I think if you just look at these graphs, I think you understand my main point. Health disparities have been persistent and long in our country. And that gap between the health status of whites and blacks is something now that I'm going to argue has become deeply structural. So we know that what began in 1900, and that's why the chart is so important, is when public health officials, epidemiologists, social scientists, physicians, and the media continued to talk about and rediscover the very notion of health inequalities, of health gaps, or health disparities. This is when that language began to be used, right? That they continue to separate the life chances of whites and people of color. And still, explanations for the gap I just showed you still pivot among insertions of a certain set of perhaps inherent genetic differences between blacks and whites, or underlying conditions and comorbidities. And some of the explanations given really echo some of the observations made by white observers about the spread of epidemic disease in the aftermath of the Civil War. So the period in the aftermath of the Civil War, 1870s or so, and into the early 1900s. And then from 1900 to 2020, is obvious to observers. We've chronicled and chronicled and chronicled this health gap. And we also know that racism has played a role in this. And some of the policies that certainly happened in the Jim Crow period ensured the enduring health consequences that are related to poverty, the overcrowding, the substandard housing, the inability of African Americans to transfer wealth between generations, inadequate education, medical care, even the subprime mortgage problem that we had a decade or so ago, as well as discriminatory loan practices, housing and redlining, food deserts, environmental pollution, and absence of certain kinds of jobs that continue to make vulnerability to infectious diseases and stress-related illnesses inevitable. So it's not racial differences inherent in the bodies of Black people versus the bodies of white people. It's racism. It's racism and not race that makes the difference. So what we see with COVID-19 is that it has once again made clear the connection between poverty and public health. So Black and Latinx people are more likely to contract and die from this virus. Why? Because, as I said at the beginning, they disproportionately work in low-paying frontline jobs. Others cannot practice social distancing in cramped apartments and multi-generational homes. These factors are about economic inequality, and as I've noted, have existed for more than a century with little improvement as the structures, even as the structures of racism have barely been changed. My colleague and I, Susan Reverby, jointly wrote an article that was published in the American Journal of Public Health last year about, it's entitled, Toward a Historically Informed Analysis of Racial Health Disparities Since 1619. And we go over some of the points that I've tried to make to you this evening about the long history of racially divided healthcare, a public health system that has been inadequate and fragmented and supported ideas of racial difference, the role of segregation, and we also talked a little bit about the role of mass incarceration and its impact on African American communities as well. We end by saying this history, and at least the sketch of this history that I've tried to provide to you this evening, is something that people should be aware of, particularly public health and medical practitioners. If we're going to make a difference in the future, in the ways in which pandemics revealed inequalities, this is the moment to do so. And understanding this long history of health disparities is something that we believe is an important part of that task. Now, when we think that, and we argued in this paper, that the need to address systemic racism should be part of the mandate of public health, including a historical perspective that could tell us where we've been and how we as a nation have failed to incorporate lessons from previous epidemics that revealed the role of systemic racism in perpetuating health inequalities. And we believe that this is a critical role for us to examine. Our good colleague, H. Jack Geiger, wrote over 20 years ago that history is important. And he says it's important because it underscores the extent to which racism, fluctuating in intensity, shifting in content, but ever present, is still a major public health problem and a challenge to the goals of medicine and science. And he continued, the failure of efforts to address racism reflects an abandonment of racial justice and equity as national goals. It's not just history. It's not just that we understand the stories, but these stories provide us, the historical record provides us with tools to understand what happened in the past and maybe make a different future. Well, so I end with one of my favorite quotes from Martin Luther King Jr. That makes clear, I think, why the historical study of health disparities is so important. And what King said is, of all the forms of inequality, injustice in healthcare is the most shocking and inhumane. So thank you for your attention this evening. Um, I know sometimes listening to someone talk over Zoom is not the easiest thing to do, but I appreciate the opportunity that you've given me to share my work this evening. Thank you.
Thank you very much, Dr. Hammonds. I'm going to turn it over now to my colleague, Dr. Lisa Pruitt, who has been looking over the questions that have been coming in via the Q&A. And as a reminder to everyone, you still have a chance if you will hit that little Q&A button on the menu at the bottom of your Zoom screen. You can type in a question that you'd like to pose for Dr. Hammonds, and Dr. Pruitt can look that over. So if Dr. Pruitt, if you will take it away.
Hey, Dr. Hammonds. The first question that came in this evening, can everybody hear me okay? Sound good? Okay. The first question that came in this evening asked, are the health issues that minority groups face unique to the United States? And if I'm going to interpret that question a little bit, I think over time, the person asking this question is wondering if there are similar disparities in other countries, and perhaps you could speak to existing scholarship or people who are working on this comparative transnational study of health disparities by race and socioeconomic class.
So there's oh my goodness, there's a long history of these kinds of studies. So even beginning in the early 19th century, certainly in the British context, in the British colonial context, there are studies of health disparities and disease in the colonial period. Certainly, the British are in places where they suffer disproportionately from certain kinds of diseases than the population that was indigenous to those particular places. There are lots of studies about that in India, in some of the African colonies, in Latin America, and it really it's all over the place. And it's shaped by some of the same kind of factors that have to do with observers thought that racial identity was a leading factor, but we know it has a lot to do with the environment. It has a lot to do with what kinds of diseases people have been exposed to in the past. And it has to do with, again, socioeconomic conditions. And certainly, so there's work that's done in the period of the slave trade that examines what happened on various, say, for example, Caribbean plantations and the differences with the plantation owners. We have studies that go through the 19th century in the US as increasing immigration from Europe. So cholera, for example, there were about 3 to 4 very significant cholera epidemics that occurred in the United States in the 19th century that disproportionately impacted the immigrant populations who lived in terrible conditions. Say, take New York, for example, in tenement houses with bad sanitation, with bad ventilation, and the rates of infectious diseases among immigrant populations of Jews, of Italians, of Germans, of all the kinds of people that were coming into the United States at that time who came through New York. There's a high rate of death among those populations as well. And so we know from those kinds of studies about a lot about the fact that living conditions and socioeconomic factors affect all kinds of groups with respect to disease. So there's a lot that's been written by historians about that period, late 19th century, a period of immigration in the US. There's a wonderful set of studies on, a wonderful study by Naomi Rogers on polio, outbreaks of polio, and the Italian community in New York City. So it's too numerous to name. There's a lot out there. And I also say again about tuberculosis, there are a lot of studies of tuberculosis as well. So yeah, so I'm an Americanist, so I know a lot more about the American context than I do about around the world, but certainly there's some very sophisticated studies about differences in outbreaks, disproportionate mortality from outbreaks of epidemic diseases. In Great Britain, lots of very sophisticated studies that really paid deep attention to issues of class. And then there are wonderful studies about outbreaks in Germany as well, where sort of social determinants of health became part and parcel of trying to understand what was happening in that context as well. So there's a lot. There's a great deal about that. Yeah, but we do know that in most cases, the other kinds of things that make a group vulnerable to outbreaks of disease have to do with existing inequalities.
Right. Following up on that, one of our graduate students here, October Kamara, has asked you, she offers her thanks for your presentation and asks, can you recommend any studies on health gaps for immigrant population in America, especially ones focusing on Latinx populations, since they have been greatly affected by COVID-19?
Well, I'm going to have a hard time bringing up titles right now.
Sure.
Why don't I do this? Why don't, as part of that answer and the answer to the previous question, I send you all back a list of those texts, because there are a significant number of them, but I do have them available. So how about that?
That would be wonderful, and that's something that we could even post for our students and everything.
Yeah.
That would be great. Thank you. Another of our graduate students asks, your work also covers how gender affects health. Have you seen trends in gender with epidemics, either the current one or earlier ones that you've studied?
Oh, absolutely. So the one that I know the most about that has to do what I've written about is issues of gender and HIV/AIDS. And certainly when AIDS was first identified, it became sort of described largely in terms of its impact on white gay men. But at the very first moment, when there was data on that it was spreading among communities and networks of white gay men, we also had data showing that they were spreading among women, both white and women of color, African American and Latino women. And that data was just going up. The numbers were going, and mortality case numbers and mortality rates were going up, not as quickly or as broadly as it was among white men early on, but it was always there. And but it was never visible and never became kind of the sort of defining population of the outbreak of HIV. And so as a result, many of the recommendations that were made from public health practitioners about how to protect oneself from HIV didn't really deal with the fact that women were getting it. And that certainly became much more evident in the African context, where there were a lot of programs that would slowly but surely develop to address the issue that that African women, certainly in Southern Africa, also had high rates of HIV. And so with COVID, it's interesting. We can't get good data yet. We've been trying. There's a group at Harvard that's been working on this, and it's just not coming through very clearly. The collection of data on what's happening with COVID is incredibly fragmented. So the CDC compiles data that it gets from the states, but different states are reporting very differently, and it's very hard to match up the numbers across different states. So we don't know yet. I think many of us are concerned about it. We'd like to be able to understand it, but the data isn't quite sufficient for us to, at least as far as I know up to today. People are trying to get the data, trying to make some sense of how COVID is impacted by gender, but it's not that we're not looking.
Okay. Another question, and I quote, the date you present suggests that Medicare and Medicaid programs have not made much difference in the health disparities between people of color and whites. Could you comment on that?
Well, I think that, as I said, I was giving you the sketch, not the deep context. So the introduction of Medicare and Medicaid has had a profound impact on Americans' health status in general. And so you have to look carefully at the data on that to find out, to see what the existing disparities are. there's still a bit of a gap, but it's hard for me to say right now what we think some of the causes of the utilization rates of Medicare and Medicaid might be part of it. Existing comorbidities might be part of the creation of the maintenance of a particular gap. The gap may not be huge in different age groups. It depends on which populations you're looking at. But I wouldn't say that the story is that it hasn't had any impact on health disparities. I think it has had a great impact in certain across many communities. But the other structural issues, which have to do with housing and employment and food, access to various kinds of food, and all of these things also continue to shape older population as well as the younger population. So we have to take all of that into consideration. So again, it's one of those kinds of things that I would come back and give you a different talk and the history of the establishment of Medicaid and Medicare is an interesting one with respect to race, and and then moving forward from its establishment to the utilization of it is also an interesting, complicated story as well.
The questions, I have to say, are coming fast and furiously here. So here's one that I think is interesting, and we're asking a lot of you tonight. So feel free to say let's move on if this one is
Okay.
taking you too far afield. Does Dr. Hammonds have a perspective on the systematic medical inequality that Native Americans face, and also in consideration to this particular pandemic?
Oh my goodness. I mean, I think that, the Native American case, I was on a panel with a scholar who works on these issues in Native American communities a few weeks ago. And the impact of COVID is pretty devastating in these communities because the Indian Health Service, for example, is already underfunded and under-resourced in its ability to address existing health questions among various Native American populations. So with that background, COVID just showed up and made it worse. So I think there's people beginning to mobilize around that. The data is being there are some new studies being published, even in the last few weeks, on the situation. But it has to do with the issues of sovereignty and what kind of health infrastructure Native build. But here's the thing with COVID. Let's just think about it. If I'd shown you a map of its distribution across the United States, it's everywhere. So people thought it could be contained, I think, early on. I didn't necessarily think so, but it hasn't been contained. And so Native American communities, as I said, were already vulnerable because of the socioeconomic conditions in many of the communities, because of the absence of a robust healthcare infrastructure. And then COVID came along, and it's just exacerbated those inequalities as well. And it's no wonder that also there's an increase in cases and deaths as well.
Okay. Here's one that asks you to pull out your crystal ball. If you had to speculate, in what ways do you think COVID-19 will change public health policy in the United States moving forward? And I would add to that, do you think the kind of publicizing of these stark racial disparities will help make any strides forward in closing those gaps in the public health sphere?
Well, I think there are a lot of people who hope so. A lot of people who think that, public health practitioners who believe that this is a crisis we cannot afford to waste. That, as I said, pandemics expose inequalities for many people in the public health world knew about these inequalities that are being revealed to a broader public through media as a result of COVID. And so the hope is on the part of these practitioners is that making the fact that COVID has made these inequalities more visible than perhaps they ever have been, that this will lead to different action than had happened in the past, that people will mobilize to provide more robust infrastructure and support for underfunded public health work in this country, that people will set goals to address health inequalities and set time frames that we're going to do certain kinds of things that we know we need to do and make it so that by the next 5 years, we will have dealt with some of these problems in better ways. People hope that it is going to push, it'll be a push to support the work of prevention, which public health does, and to deal with some of these problems that people have noticed before. The former president of the American Public Health Association, Dr. Kumara Jones, has been leading an effort for public health agencies at the state level, as well as the national level, to really address issues of systemic racism. And some cities and some local and state governments are beginning to say, yeah, racism is part of the problem that we have to address if we're going to get these inequalities, if we're going to really end and address these inequalities. So there's a lot of movement now that people are taking advantage of. And my hope, I don't have a crystal ball. My hope is that the lessons from the past will be learned this time, and people will think hard about the role of inequalities and how long they persisted, and that this might be the time we could take advantage of that knowledge and do something different.
Following up on that, a couple of people have asked similar questions. One asks, as a white healthcare worker, what can I personally do to intervene? And then another person asks, what would you say to the average college student? What could the average college student do to address this issue of health inequality?
Wow, those are really good questions. I think for the healthcare workers, I think what has to happen is really, again, it's really understanding this history. So these inequalities exist, and the ways in which they manifest themselves is important. So let me give you an example that was the subject of a recent article in the New York Times. One of the symptoms that people identified in these past few months about COVID is that some people show discoloration of the skin on their toes and extremities. Now, one of the things that so the person who wrote this article is an African-American female dermatologist. And she knew that in her whole training as a dermatologist, they had never learned about how you recognize skin discolorations on a whole range of skin colors that were not white. So she wondered if people of different darker skin colors were actually, who might have COVID, that people weren't registering those particular symptoms because they didn't recognize those symptoms on people who were not white. And she talked about in her article about the fact that dermatology was not as the way it was taught. It was taught with photographs and images of always of white people and not of people of color. So all those symptoms, she argued, were being missed. So for healthcare workers, those kinds of things that you hadn't really thought about before. The fact that this is an article, this was discussed in an article in the New York Times. So a lot of people were made aware of it. You have to ask yourself, wow, have I ever thought about this before? That did anybody come into, if you work in a clinic or a hospital setting where people are coming in with symptoms of COVID, how much have you noticed? And so it's a time when we can get these kinds of issues out in the open. This is certainly something that African-American patients had complained about for a while. There were some studies that showed this, but it's not something that was generally discussed, right? And so I think for healthcare workers now is a time to make yourself aware of how many things like that have just been made invisible, and that think to ask a question about how symptoms that supposedly would tell us something about someone's status might be racially biased. People are also looking at pulse oximeters, which have a built-in race correction, and that the reading that you get for a Black person and the reading you get for a white person might be different, and the Black person actually might be sicker at a different reading than it is for a white person. Those are the kinds of things that we should be talking about now and thinking about now, and people are publishing about those things now. Now, a historian of medicine, we've been reading about how those kinds of technologies have had problems with correcting for racial difference for a long time. But it's not like people read history of medicine every day. Now, people are concerned about these issues, and so there's much more. It has much more visibility. For college students, that's an interesting issue. I think for college students in general, right now, perhaps the biggest thing is to make to really spend some time. I guess I make it as a historian, and maybe Lisa and Emily would agree. It's time to learn some history. It's time to learn more history, because I think these are important sets of issues that educated people ought to really be paying attention to. And what we get from the history is learn how to think critically about these questions that affect policy and policies you may be asked to respond to in the face of an epidemic that, as of right now, is still not under control. So the more you know, and the more you know how to think about these questions, then I think that's important. So history.
Yes, I would agree with you, as would all of the historians listening right now. I want to ask Dr. Nelson how long we're supposed to continue. I don't want to go on with the grilling beyond the time we're supposed to.
What I've announced was 6 to 8, although I don't want to tax Dr. Hammonds too much. Select at your discretion.
Okay, I just wanted to make sure. All right, because I still have a whole raft of questions here that I could.
Well, you have to invite me back.
Yes, we will. I think that this is a sign that you need to, when the pandemic's over, that you need to make a trip here and give us the benefit of your observations throughout the whole pandemic. Let's see. Let me choose something that. One of my colleagues asks about the, well, she poses a couple of questions, and I'm going to give you your choice to answer both or one or the other. Her first question is, class the major factor as it intersects with race? For immigrant communities that experienced transgenerational poverty, are the health disparities as pronounced as those in racialized communities? And that's a complex question. Do you want me to read the other one, or do you want to tackle that one?
Yeah. I mean, I think people are addressing that in different ways. Let me say how I think about it. I've tried to. So when I first wrote about the history of diphtheria, which was a very virulent disease for children, so across the 19th century. Many children under 5 died of diphtheria, and that was before we had diphtheria antitoxin, and then we had for treatment, and then we got toxin antitoxin for immunization. And I wrote about it because I was really interested in trying to understand the relationship between laboratory science, clinical medicine, and public health in New York City. What better place to try to understand all those things?
Sure.
But what we found is that looking at the immigrant populations, who was a larger population in New York City in the late 19th century into the 20th century, the living conditions, there's a big debate about whether or not was it the living conditions that changed, that had a greater impact on that the burden of infectious diseases became lower, or was it something like immunization? Clearly, both have an impact, and people stand on different sides as to which one had the greatest impact, and that's a very complicated and longstanding discussion. But I think that if you add to that intergenerational poverty and issues of disenfranchisement and economic insecurity, you're looking at something that can um, that doesn't have the we can't see how change has happened over time as easily, right? Because the social conditions did not change as significantly over time. So people lived in tenement house districts in New York City. If your family lived in the tenements for generations, yeah, there's a heavy burden of illness there. But as other immigrant groups began to be able to move out of those districts into better housing, with better sanitation, with better other health care, then the situation changes. So I do think that we have to pay attention to what I was trying to describe. In the long history of these other social determinants that African American communities have suffered, that some other communities have not. And so it's not a simple, I don't think we can get to it just as sort of looking at race and class. But Du Bois asked that question in his 1906 work. And he said, look, if I look at tuberculosis rates among the immigrant populations who work in the meat packing districts in Chicago, I see higher rates of tuberculosis among that population than I do on the African American populations. And he says, so is it race? But then you show me how it's race, and it's not the conditions under which people live and work. So we that's what we get into when we try to answer that question. We have to try to look over time and look at the particular populations. And that's also something that back to the previous question about Native American communities, the fact that the Indian Health Service has been such a underfunded, not able to bring adequate health care to many of the nations that depend upon it, then we see what we see, which is continuous burden of disease.
You mentioned the W.B. Du Bois study again, and I'm going to tweak one of the questions that came and kind of put my own spin on it. How was that, or do we know anything about the reception of that study in the African American community or in the white community? Did especially outside the African American community, did anybody pay attention to it?
So yeah, this is within the African American community, small numbers of social scientists at the time, they were aware of how of Du Bois's work, and he trained a number of the next generation of social scientists who continue to work, African American social scientists who continue to work on those issues. But no, it was not read or commented upon by white social scientists of the time. But when Gunnar Myrdal wrote The American Dilemma, a number of the issues that are addressed in that magisterial work were similar to what Du Bois had, the kind of questions Du Bois had asked, and some of the social scientists, African American social scientists who worked with Du Bois, worked on American Dilemma as well. So Alden Morris has this great book on Du Bois's work as a social scientist now that shows no, it did not have the impact that one would have expected it to have on the intellectuals who were the leaders of American social science at the time.
Okay, I feel like I'm putting you through your doctoral oral exams again. So, but we still have some interesting questions, and here's one that takes a little bit a different direction than some of the others we've had. This person asks, may I ask what can be safely said or inferred about the geographical signature of an outbreak's origin? Does globalization exacerbate or create pre-existing social, political, and economic deficiencies in any given geographical location?
Well, that's a really hard one.
A big question.
I don't think I can speak to that one. I think it's very complicated. The kind of conditions that make it possible for some kind of virus to take advantage of the local situation is, that's hard for me to say right now. This is a new virus. I don't think we know enough. People are beginning to study and trying to track it and see what happened and why it happened and how it happened, why it's spreading the way it did. It has some interesting quirks in its spread as well that people are still, of course, trying to explain. It's going to take a while for people to understand what happened.
Sure.
So I'll just leave it at that. I think that's a great question. I think people will be asking that question.
That's a question for someone to write a dissertation about.
Mm,
I will follow up just with a comment on that. I have, in my reading and keeping up with the current pandemic, found it interesting that by most accounts, and I'm not right up to the minute, so this could have changed since I last read, by most accounts, sub-Saharan Africa has fared a lot better than other places in the world, including Latin America. I don't know what to make of that.
I don't either. I don't either. And
I'm glad, but I don't know what to make of that. I think
it's interesting. It's incredibly interesting. And I think it's going to, people are really, really trying to figure out what exactly is the difference. And so that's as much as I could say. It's very interesting that how this is working, how this is spreading. And in some ways, it doesn't quite make sense, but we just don't know enough.
right. Yeah, it's very challenging in understanding and following the news on this current pandemic, to for people to understand that we just don't know. I
Yeah.
mean, I think that's really hard for the general public in particular, who don't spend a lot of time thinking about these things, to really understand how long it takes to get to know a virus, and to understand what the impact will be over the long term. And I think that's one of the, as historians, we're not necessarily equipped to help understand the current virus, but
Right.
certainly to convey to our students and to other audiences the extent to which uh, the ways in which knowledge about viruses in particular have unfolded over time.
Yeah.
I think your study about diphtheria is a good example of that. Uh, it takes time for people to unravel. It takes sometimes new technological developments to enable scientists to understand how things are working.
Absolutely.
And I think that that is particularly challenging, I think, in our current political climate where, in the political world, nobody wants to hear, we'll know some answers to your question in 15 years. They
Exactly.
want to know what you can do for me yesterday.
Yes.
uh,
I think you're absolutely right, Lisa. I think one of the things that certainly in my years of studying disease and society, the uncertainty is at the center of all these narratives, all these stories, all these outbreaks. You just don't know, and I think that has been hard, particularly in the American context, for people to hear. This is what when somebody says, this is what we know today, and this is what we think is the right thing. It could change in 2 weeks. It could change in a month. We're not making stuff up. It's just that it changes. This is what we can know now.
yes,
This is what we can say based on what we know now. It's hard to live with uncertainty. This has been terrible. People have lost loved ones. They've lost their livelihoods. They've lost. It's terrible, as outbreaks of epidemic diseases always are. But I think the lockdown, I think, has really put a lot of us in watching and news and listening to things that we wouldn't ordinarily pay attention to because we were out doing our lives. And the sense of uncertainty was not so visible, but I think it's visible now. And people want, the definitive answer. It's just, it's hard to get the definitive answer right now. We just don't know enough.
Another question that I'm seeing here on the screen actually would be a good follow-up. Let me frame this first. The audience member is asking about the historic distrust of healthcare in African American communities,
Mhm.
and references Henrietta Lacks and the Tuskegee experiment and its impact on clinical trials. And I wanted to kind of add to that. She asked you to speak about that, but I want to add the twist to that, because I've just in the last few days been hearing and reading about the challenges with the current clinical trials of vaccines. I know I tried to volunteer for one that's being run out of Vanderbilt, and the response that I got was that they were only recruiting people who were in uh, it was a list of things. So it was basically communities of color.
Yeah.
But then I read online some comments. There's a real apprehension about this idea that people in communities of color should be prioritized as subjects for scientific research. And I think I understand the reason why, because those communities are disproportionately affected by the disease, and there need to be representatives from those
Yeah.
communities in the clinical trials. But you could flip it around and it would seem as though uh, disadvantaged populations are being uh, exploited to benefit the larger good. And so, how do you respond to those kind of conflicting ideas? There is very justified distrust, and yet there's very much a need for minority populations to participate in these trials.
So I hope this is the last question, but this is really the heart of the matter right now. There are
Mhm.
meetings being held all over the country, from the National Academy of Medicines to various universities to private companies that are working on vaccines. How to address this issue? First, the deep distrust on the part of especially African American communities, that is directly related to the kind of stories that I was trying to tell. And it gets reduced to the shorthand, or this is about what happened to Henrietta Lacks, or this is what happened because of the mistrust is due to what happened in the Tuskegee experiment. And I'm actually working on another paper with my friend Susan Weatherby right now. Yes, those things are known, and those things offer, as African Americans know those stories, that does make one skeptical. But it's really the everyday racism that they encounter in the medical system that also provides a great deal. As my father used to always say, I don't know what happened in Tuskegee, and I'm not interested. But I tell you what made me angry last week when I went to my doctor.
Mm.
He was white. So it's a lot of everyday racism that is also deeply supportive uh, that uh, uh, that has led many African Americans to have a certain kind of distrust. The enrollment into the vaccine trials is getting complicated, in part because the article that was in the Times, I think it was just last week, it said, "Why should Black folks be guinea pigs for white folks?" It's roiling right now. I and the explanations for let's put it in a larger context. The largest context here is we're in the middle of a pandemic. The mortality rates are high, the case numbers are high. And if we're on the cusp of getting we really are on the cusp of getting vaccines, how do we as a society come together and decide who is most deserving to have those vaccines as soon as they are available? And I think the push for getting diverse people into the clinical trials for the vaccine is right. But then at the end of the day, the decision is going to still have to be made. And I don't think we have a frame yet that really brings to the fore issues of equity and justice and in such a way that we can, in our really fractious political moment, really understand and come together as communities to think about who is most deserving at this time. I think there's a lot of factors in it. I think we're going to hear a lot of stories about different perspectives on this.
Mhm.
But at the core, the heart of the matter is, how do we as a society decide such things? And that's going to be on the table for all of us in the coming days and weeks.
Thank you very much. And we will let you off the hook now. We could go on with this all night, I'm sure. We will definitely need to have you back, especially post-pandemic, so that you can give a retrospective view on it once it's in our rearview mirror.
And
Um,
I heard you guys might have good fried chicken down there too.
and good barbecue. So we can definitely feed you well. And I'm going to turn it over now to Dr. Nelson and Dr. Barron to close out the program. I want to thank you again for taking the time, not only to give your presentation, but your patient cooperation with the a lot of questions, many of which could have had their own lecture to address. So thank you very much. I appreciate your time.
Thank you. Thank you.
I'll turn it over to my colleagues.
And I'd like to say, again, thank you very much to Dr. Hammonds for joining us and for being so patient and helpful in answering so many questions. To those of you who are attending, I want to thank you as well for joining us. And if you had questions that we weren't able to answer, I apologize for that, but you were so interested in such a valuable, timely, and insightful talk that it just overwhelmed us and our presenter.
May I interrupt you just for a moment? There was one question for you to answer, which is, will we have an opportunity to listen to this presentation at a later date?
I was just about to get to that. Thank you. Yes, we are making a recording of this, and we are going to make it available for reviewing. You can probably a couple of days, either on MTSU's in-house TV channel, True Blue TV, which you can access through the MTSU website. And we're also going to be looking to post it to MTSU's YouTube page or YouTube channel. And both of those should have subtitles enabled as well. That is all the information I have. Dr. Barron, do you have anything that you'd like to add before we head out?
Just another thank you to Dr. Hammonds. We had incredible audience participation. We have, Dr. Perez can attest that we have a lot of questions we couldn't even get to. So obviously, a lot of folks were super excited to hear about your research, and we're just so happy that you were able to join us, even if just virtually in 2020. So thank you so much.
Thank you. Thank you. I really enjoyed it.
All right, then. On behalf of us here in the History Department at MTSU and on the Strickland Committee, again, we'd like to thank Dr. Hammonds and everyone who attended, and wish everyone a good evening.
Thank you.